My name is Mark Schaefer, Vice President, System Innovation and Financing at the Connecticut Hospital Association. We appreciate this opportunity to submit testimony concerning House Bill 5488, an act concerning various revisions to the public health statutes. CHA opposes sections 2, 5, 6, 11, and 12 of this bill. CHA has concerns with section 2, which seeks to penalize providers who fail to report adverse events under 19A 127N, unreported adverse events which occur infrequently. We are puzzled by the need for more punitive measures when there are already effective processes in place to align reporting with the adverse event program requirements. CHA and the Department of Public Health have an existing open and collaborative process to ensure discrepancies in reporting of adverse events are resolved and providers obtain clarity so that the system collects accurate reports. Punitive measures can foster over-reporting, which muddles the system and detracts from the purpose of making care safer. Instead, DPH could increase real-time feedback opportunities so that events meeting reporting criteria are accurately captured. Sections 11 and 12 of this bill focus on the injection and infusion services provided by hospitals in off-campus settings. The majority of this care supports cancer treatment, which typically involves frequent infusion of chemotherapy or other drugs by nurses or other hospital staff under a physician order. Section 12 of the bill would introduce an outright prohibition on commercial reimbursement for these services when provided off-campus. Stated another way, hospitals and the clinical staff who support these services would receive no commercial payment whatsoever for providing these services, other than for the cost of the drug. This would likely result in an immediate cessation of such services and the loss of access in clinics across the state. It would also introduce the needless loss of tens of millions in hospital revenue at a time when hospitals across the state are experiencing extraordinary financial challenges. Low-income patients on Medicaid rely on the access provided by hospitals, access which they might not otherwise be afforded in community practice settings. In addition, hospitals often serve patients with more severe or complex conditions that can be effectively managed in non-hospital settings, that cannot be more severe than can be handled in non-hospital settings. There's no public health rationale for making it illegal for hospitals to collect commercial reimbursement for these services, which would result in the elimination of these care settings entirely and access for all patients who rely on this care regardless of payer. Section 5 seeks to remedy a problem where none exists. Currently, law allows the collection of prohibited facility fees if those fees were already included in a contract between a hospital and a commercial health insurance payer. Once the contract reaches its expiration, those prohibited facility fees may not then be collected. Section 5 makes a violation of current law an unfair trade practice despite the lack of evidence over the past 8 years that current law is not being followed. The intent of section...
Mr. Schaefer, but your time is up. Thank you.
Thank you.
Actually, Mr. Schaefer, if you want to just complete your thought, please.
All right, it's a short one. Thank you. The intent of section 6 is unclear to us. We support the prohibitions regarding medical debt to a credit rating agency, but oppose the attachment of an unfair trade practice violation. It's not exactly clear why this change was being made at this point. So we're interested to learn more about the intent. And that's it. Strongly encourage the committee to strike those particular provisions of the bill. Thank you.